Hello class, and welcome to this e-lecture on psychopharmacology. This week, this session, we will be exploring anxiety and obsessive-compulsive disorders. There are several different diagnoses under anxiety disorders: separation anxiety, selective mutism, specific phobia, social anxiety, panic disorder, the specifier of panic attacks, agoraphobia, generalized anxiety, which is the most common, or well known of the anxiety disorders. Substance or medication-induced anxiety due to medical condition, and other specified or unspecified, that catch-all category. OCD has several diagnoses as well underneath it, which include obsessive-compulsive disorder, as well as body dysmorphic disorder, hoarding, trichotillomania. I'd enjoy saying that one as much as you will, excoriation, substance and medication-induced OCD, and OCD due to medical condition. We also have our catch-all other specified or unspecified categories. Okay, let's look at anxiety disorders first in preparation for your case study this coming week from Ariadne's thread, The Many-Chambered Heart. We're going to look at separation anxiety first. This is the most prevalent anxiety disorder for children less than 12 years old. It decreases in prevalence with age. By adulthood, separation anxiety is far less of a concern compared to some of the other anxiety disorders. It is most problematic during childhood. It is somewhat attachment related. The idea that the child leaving the caregiver generates anxiety, and there is some kind of dependency around the caregiver. Symptoms have to last for 4 weeks in children or more than 6 months in adults, and this causes distress or impairment. The distress might be distress when anticipating or experiencing separation from home or major attachment figures. Major attachment figures usually means parents or guardians. Excessive worry about loss of major attachment figures. Excessive worry about the event causing separation from major attachment figures. So, for example, worries about a car accident on the way home that might rob the person of their parent for the rest of their lives. Staying home for fear of separation, meaning the parent is at home, the child has difficulty leaving the house to go to a friend's house perhaps, maybe even go to college later on because they fear that separation. Fear or reluctance to be alone. This one is particularly notable because you will find children who you will work with in the future who cannot sleep alone, even at the age of 12, 13, 14. They feel like they have to be with a caregiver in order to sleep through the night, and that causes significant anxiety for the parent or guardian because they don't feel like that's appropriate, yet at the same time the child will not sleep, will bang down their door at 3 o'clock in the morning, they just can't sleep. It becomes a treatment issue. Reluctance or refusal to sleep away from home or without the major attachment figure. This can become significant during the teenage years because most adolescents, especially during middle school, really connect through sleepovers and through just going on, for example, camping, going out on summer camps or those kinds of events. And if you can't do that, then you lose important developmental tasks that you just can't complete otherwise. Repeated nightmares with the theme of separation is an important symptom, as well as complaining about things like physical symptoms with separation. That might include stomach upset, it might include dizziness, nausea. Some treatment planning for separation anxiety, since you probably will be seeing this, especially if you work with children. It particularly manifests as an aside in the school system because the child will refuse to go to school because they don't want to be away from the parent. As a method of prevention, you could look at family systems work, reinforcing wanted behavior, for example, going to school, being with friends outside of the home environment. Extinguishing unwanted behavior. So not allowing the child, for example, to stay home when they complain of stomach aches or they are just afraid of the parent leaving. Spending more quality time with the parent, so making sure that the child and the parent have quality time together. That's also true in adult relationships if there's separation anxiety. And identification of supports, so making sure that, for example, if the child is having difficulty separating, that there is someone around who can help with that. Because believe me, children will cling to caregivers, and they can be very difficult to separate from caregivers at times, just because the child is so terrified of losing the caregiver. Intervention or treatment can include CBT, systematic desensitization, which is this slow, step-by-step process of the child becoming more acclimatized to being away from the parent. So, for example, if a child is really struggling with this and they're having some major issues with truancy, you might have the child go to school for a half day at first, perhaps even just 1 day a week, and then, or even a couple of hours, and then gradually build up to half day, full day, every day of the week, full inclusion. It might take a while, but step by step tends to work better than just saying to the child, you must come to school 5 days a week for the entirety of the week, which maybe is not feasible. Reality therapy can be useful. That good old Dr. Phil question, what's that doing for you, can be useful, emphasizing choice, that the child, the adult with separation anxiety, does have a choice in how they respond to separation. Attachment-based interventions can be useful. This includes playing through the importance of having needs validated. So if a child feels like they have a particular need, that the parent can soothe them, that's validated at appropriate times. And then parent education can be very useful from an Adlerian perspective, because parents do need some guidance in how to handle this kind of behavior. A lot of the time anxiety is top-down, meaning the parent feels anxious before the child does. And so working through the anxiety with the parent is very, very important with separation anxiety. I will add that in my clinical experience, most of the more severe cases of separation anxiety have had root issues that has driven the anxiety in the young person, which includes things like a parent being hospitalized while the child was young. That can just generate feelings of panic of losing the parent. It could have even been losing a grandparent and then fearing that they will also lose their parents because of that. Or it can be a more significant loss, things like, for example, divorce, parent moving away and not seeing them for a long period of time. Even parental death can also occur. If those things are present, there tends to be some kind of deeper root that's causing that separation anxiety. Sometimes that deeper root is not there, or it's not as apparent to you, meaning the child may have been triggered just by a minor car accident when they were younger, and that made them fear for their parent, for example, or fear for others around them. And those things may or may not be known, conscious to the child or adolescent who's experiencing them. It just depends really on the child or adolescent. Selective mutism, moving on from separation anxiety. This is when you have a person who for more than a month does not speak in social situations when speaking is expected. More than 1 month, that's a long period of time. It's not just an adolescent being difficult one day and deciding not to speak to their parent or anyone else. I don't know if you've seen the movie Little Miss Sunshine. There's a adolescent male character in that movie who refuses to speak for prolonged periods of time. I believe he was doing that for more than 1 month, so he would qualify for this, but for most adolescents it rarely lasts longer than a day or two. So anyway, with selective mutism, it is an anxiety-based response, meaning the person does not speak in social situations despite speaking in other situations. So they may, for example, talk online, they may talk with a family member in a house, but outside of that, for example, at school, or in a clinic setting at counseling, they may not open up at all. It interferes with occupational or educational achievement or social communication, obviously, because it's very difficult to do well in school if you're not talking to anybody. You can't answer questions if you're called upon. You can't answer questions if you don't understand the material. There's a caveat here that selective mutism cannot be attributable to language barriers, meaning if someone just cannot speak English as their first language and English is the language spoken in the predominant social context, that person doesn't have selective mutism, they just don't understand the language. Specific phobia. This is commonly known as a variety of phobias, heights, animals, natural environment that cause a person to avoid certain situations. So the criteria are for more than 6 months, the fear or anxiety about the object or the situation result in the person avoiding the object or the situation or enduring it with intense fear or anxiety. This is out of proportion with the actual danger. And the social cultural context has to be that the person genuinely is not in danger, or that there isn't a expectation for a fear-based response socially, culturally. So, for example, if someone has a particular aversion to, I don't know, a type of animal based on their spiritual religion or practice, if that exists, then you cannot diagnose the person with specific phobia since it's culturally acceptable to have that fear-based response. The coding is based on type for specific phobia. It depends if you have a phobia to a particular animal. Most common would be spiders, arachnophobia, or just a variety of other kinds of animals. Snakes is also common. Natural environment. This can include things like thunder or lightning. You would definitely work with some adults as well as children who are so terrified of thunder or lightning that they will sit there and they will just ruminate on the possibility of thunder or lightning if they see it on the newscast, on the meteorologist's report for the day. There are children I've worked with who have autism, who have been even adolescents with autism, who have been incredibly anxious about the idea of thunder or lightning and this just fear that something awful will happen. I was in Virginia, by the way, a couple years ago when there was an earthquake, a very minor earthquake, but it was enough that we had a variety of children admitted to the psychiatric hospital that I worked at for at least a year afterwards, and they would complain of this fear of earthquakes. So specific phobias can be caused by recent events as well as just perpetual ongoing issues such as thunder and lightning. Blood injection injury is also a fairly common one, this fear of needles. I think many children have this, but it can be more severe than others. I've worked with a number of children, adults as well, where you've had to draw blood when they're admitted to the hospital. It's part of their routine lab work. And that can require full body restraints just to get the blood out of them because the person is so terrified. Situational, which has to do with this one's a little more complicated. I'm pretty sure, I might be wrong, this one has to do with things like fear of heights. I can't recall off the top of my head, but anyway, situational is a type of specific phobia. Social anxiety disorder or social phobia is becoming something significant to be aware of, attentive to, particularly if someone is in a field where they're expected to be presenting in front of large audiences or audiences at all. This can be something to be mindful of. To have this, to meet the criteria for this disorder, you have to, for more than 6 months, have fear or anxiety about exposure to scrutiny in social situations. Scrutiny meaning critics, people observing you and making judgments about you. Could be positive, could be negative, but they're making judgments. There is a fear of anxiety symptoms being negatively evaluated by others, so others will see my anxiety, and this will cause me humiliation, embarrassment, even rejection by others. Fear has to be out of proportion to the threat, meaning if there really is a possibility of you being horribly shamed by someone that doesn't qualify. And in children, this must occur with peers, not just adults. Social anxiety does persist into adulthood and is in fact, more well known in adulthood than childhood a lot of times. A specifier is performance only. That is when someone is standing in front of others, like on a stage, for example. But social anxiety also includes things like being in crowds, or having things like work a cash register or interact with people on a regular basis where they are afraid of being humiliated, embarrassed, or rejected. An example might be a couple of clinical examples that you want to pay attention to. If you have someone who works in the artistic field, particularly a musician, for example, or someone who does performance art, dance, if they have performance anxiety, that will take a significant toll on them because they are expected to perform regularly in front of others. In addition, speakers, could be politicians, could be at workshops, maybe even some of you have an excessive amount of anxiety about presenting in front of the class. That is part of social anxiety disorder, but again, I wouldn't diagnose yourself with that, but it gives you an idea about what is required for that performance-only subtype. Where it becomes more disabling, I think, is when it interferes with everyday interactions with people, especially things like basic work tasks, working with people and fearing that negative evaluation, humiliation, embarrassment, and rejection. Agoraphobia is basically it's known as being not wanting to leave the house. The broader definition is this fear of large open spaces, which has to do with this fearful avoidance of difficult to escape situations in the event of panic or incapacitating, embarrassing symptoms, and these have to last for more than 6 months. So for example, this fear about being incontinent and being seen in public, or this fear of having a panic attack, or a fear of needing to do some kind of behavior. It might be something even like insulin injections, or a variety of other things where you're fearful that you won't be able to get out of a situation to do what you need to do, and that it'll be embarrassing to you and incapacitating. People who have agoraphobia may require the presence of a companion, and this can be significant because the companion typically will be clung to by the person with agoraphobia, and the person with agoraphobia will tell the companion that they can't leave the house, they can't go out, they can't go into crowds. For example, they can't go to stores, they can't do grocery shopping if their companion is not with them. So a large onus is placed on the companion for their functioning. Fear occurs in at least two or more of the 5 situations, including public transportation, being in open spaces, being in enclosed spaces. This could be large enclosed spaces like a stadium, standing in line, being in a crowd, and being outside of home alone. You may have watched a famous film called I can't remember the full title, but it has to do with a character called Gilbert Grape, and the mother in that film has agoraphobia. She does not leave the house for months and months at a time, and eventually does leave the house when her son gets into trouble, but her leaving the house is seen as a major discovery within the community because she doesn't leave the house often. She has agoraphobia, and she is morbidly obese in the film. I think it's called What's Eating Gilbert Grape. Anyway, treatment planning for phobias. I include here social phobia, specific phobias, and agoraphobia. Prevention is identification of triggers. What seems to make the person most anxious? It may be a specific phobia. It may be just being in social situations that one fears rejection, one fears criticism. It may be just being in open spaces and feeling like one cannot leave, or in closed spaces. Cognitive preparation does help by assisting a person to plan ahead for what it might be like to be in those situations. Identification of healthy coping thoughts is also very useful. So what can you think in that moment? How can you talk yourself through that situation so you can remain in there and do your best? I'll also add, in terms of intervention and treatment, that this self-talk goes along very nicely with systematic desensitization. I've worked with many young people and adults who have difficulty doing things like going to the store to get groceries. And you have to be able to talk them through, okay, how are you going to get to the store? What are you going to tell yourself to get out the car? What are you going to tell yourself when you walk through the front door? What are you going to tell yourself when you start walking down the aisles and you see people? A person has to be actively talking to themselves throughout all that and making very short, small efforts, again in a step-by-step fashion, in order to accomplish the goal. So you can't have them just going into Walmart for a couple hours and coming out on a Black Friday, for example. That might be devastating to a person. You might have them walk into Walmart for 5 minutes and then come back out, and then try 10 minutes next week or what have you. But taking it step by step helps. A clinical example, this is a fun one that I had a couple years ago. I had a young man who had a specific phobia about Sasquatch and Slender Man, which was new to me. I'm still not completely sure what that figure's all about, but Sasquatch was the major one we worked on. He was having nightmares about Sasquatch. He was very clingy to his parents, refusing to leave the house, refusing to go to school. And initially I was thinking there was some deep root to it, like he was afraid of a shadowy, large male figure, perhaps. Perhaps he'd been physically abused. I didn't know that. None of that came out. I guess the young man had watched some scary movies involving Sasquatch at some point or another. Bigfoot and the Hendersons, who knows? It could have been anything that had scared the poor guy, but he was only 8 years old. What we worked on in therapy was kind of a creative intervention. I'd printed off about maybe 15 or 20 images of Sasquatch, most of which were kind of silly. You see the image on the screen here, the Sasquatch in the Jack Links adverts or what have you, and asked one at a time to this young man, had him look at the images and tell me if it was real or not real. And most of the time it's a man in a suit, right? And he was able to tell me not real to each of the images and start laughing as we'd go along, because I would just find really goofy pictures of Sasquatch. And we continued to do that, and over time he felt ready to leave the hospital and try sleeping at home. He was sleeping very well in the hospital, and try going back to school. So just a kind of simple illustration of how you can use systematic desensitization, even just in terms of imagery, to help someone overcome a phobia. Panic disorder. This is a really important one to be mindful of. A lot of people do struggle with panic disorders. This is recurrent unexpected panic attacks. They usually have more than one attack, which is followed by more than 1 month of things like the cognitive piece, persistent concern or worry about the attacks, having additional ones, significant maladaptive behavior change such as avoidance of antecedents. I won't go running anymore because I'll have a panic attack. I won't take that route to work. I won't leave the house because I'm afraid I'll have a panic attack. I'll avoid that meeting because I'm afraid I'll have a panic attack. Even if the meeting or the exercise or the route to work really has no bearing on why the panic attack happens, the person makes these inferences. They think, I must do something to avoid them, therefore I will start to develop this cognitive set that these set of events in my life cause these panic attacks, and if I can avoid those, I'll avoid the panic attacks. So that's when you start to see the significant maladaptive behavior changes. It's in many ways an adaptive response. A person is trying to not have panic attacks. They're trying to organize their life around prevention of them. Unfortunately, most of the time there isn't a good reason why people have panic attacks. They occur for no good reason. They come out of the blue. And so helping a person just to be able to tolerate and sit with and accept those feelings when they occur is really important, because the more a person starts their thought cycle of how horrible is this and I'm going to die, it makes the attack a lot worse. In addition, a person can be taught to prepare for those by noticing them when they're coming on and engaging in things like deep breathing and progressive muscle relaxation. We'll get to that in a slide coming up. You should know that panic disorder has some cultural issues associated with it. I'm not even going to pretend that I can pronounce these. Trungio is my best guess. This is hit by the wind. It's from Vietnam. Ataque de nervios. This is attack of the nerves in the Latin Americans. And Kial attacks, I guess, which is soul loss in Cambodia. All of this looks very similar to panic attacks, but is called something different. And remember, if it is culturally acceptable, it is not a mental disorder in that country or among that culture, even if they're in the States, for example. Okay, here are the specifiers for panic attacks. Remember that you can have any disorder pretty much and have panic attacks as a specifier. So major depressive disorder with panic attacks, post-traumatic stress disorder with panic attacks. Does that make sense to you? It's an add-on. So there's panic disorder, which is the formal diagnosis, and there's this add-on category with panic attacks. That's the specifier. So it can occur in the context of anxiety, depression, PTSD, substance use disorders, medical conditions, and that's when you add the with panic attacks. If panic disorder is coded, obviously don't add with panic attacks. So you wouldn't say, for example, panic disorder, and then second diagnosis, generalized anxiety disorder with panic attacks. You don't need that. You already have panic disorder. You need 4 or more symptoms to qualify for a panic attack specifier with panic attacks. All of these things are very typical to panic attacks. Palpitations, this increased heart rate, the sense of my heart going to explode, I'm going to have a heart attack. Sweating, trembling or shaking, shortness of breath, smothering sensation, feeling like I can't breathe. Feelings of choking, similarly to that. Chest pain or discomfort. Nausea or abdominal dizziness, feeling dizzy, unsteady, lightheaded or faint. Usually this has to do with breathing. Chills or heat sensations. Paresthesias, this is numbness or tingling sensations, more of a neurological symptom. Derealization or depersonalization, as you might recall from PTSD, this feeling of either things being a dream or being outside of yourself looking in, kind of floating. Fear of losing control, of going crazy, and fear of dying. Okay, treatment planning. I'd mentioned some of these. You want to help clients identify physiological arousal when it occurs. How do they know that their body is responding? How can they tune into their increased heart rate, their increased breathing, or feeling like they're hyperventilating? You want them to also identify healthy coping thoughts. How can you think more productively, more healthily about this situation without dipping down into feeling like you're going to die, you are not going to be able to handle this, it's going to be horribly embarrassing, etc. And reducing stress is also important. I'll share with you, there was a period in my life where I did have I believe it was one panic attack once, and that was when I was working night shifts, and I think my body was stressed. I don't know if I was mentally stressed, but I think my body was just stressed working that kind of lifestyle. So just be aware of that sometimes if you change a person's lifestyle, it can make a difference. I was told by, I think I actually went to a doctor the next day. I think it was just an outpatient appointment, and he told me you need to get off night shift. So I did, and it was successful for me. Intervention or treatment. CBT, you can use things like cognitive restructuring, deep breathing, meditation, grounding exercises. You'll notice here CBT is very useful for a lot of the anxiety disorders. Reality therapy can be useful by normalizing the experience. You're not going to die, and emphasizing choice again, that you have choices in every situation, even when you feel like your heart is beating rapidly. This also has an existential flavor, of course, this idea of choice. Generalized anxiety disorder, let's look at this next. One of the most common mental disorders. This is when you have for more than 6 months excessive anxiety and worry occurring more days than not about a number of different events or activities, the anxiety is difficult to control, and you have at least 3 of 6 symptoms. You only need 1 symptom in children, by the way, for this. Restlessness, keyed up or on edge, easily fatigued, difficulty concentrating, mind going blank, irritability, muscle tension, and sleep disturbance. Things like difficulty falling asleep, difficulty staying asleep, or restless, unsatisfying sleep. Also early morning awakening, I'll add that too. You notice that some of these symptoms are very similar to depression: difficulty concentrating, irritability, sleep disturbance. The big difference is this feeling of restlessness, of being easily fatigued, and being tense. I think it's the keyed up, tense part to it, is in addition to the worry, the excessive worry, that really differentiates generalized anxiety from depression. But because of the shared symptoms here, you can understand why a lot of the times people with anxiety are diagnosed with depression and vice versa. It tends to be a fairly common co-occurring disorder, anxiety and depression, generalized anxiety. Treatment planning includes, for prevention, psychoeducation on healthy eating, sleep, and exercise. You want that person's lifestyle to be changing somehow. My guess is not everybody is going to have productive eating, sleep, and exercise habits who has generalized anxiety. So that's an easy first course of treatment that doesn't require medication. Pros or cons of worrying can be worked out. I often find people worry at bedtime in clinical work, so I will have them or even just journal down their worries for the evening and just pick it back up the next morning, and it helps them to sleep better if they can let go of the worry. Impact of substance use: some people will drink and that won't help them in terms of their anxiety, because drinking, of course, is a depressant. Drinking alcohol. Body awareness and mindfulness can also be useful, helping a person to, again, be more aware of, accepting of their anxiety in the moment when it occurs. Intervention or treatment can look like cognitive restructuring, thought stopping, self-monitoring, helping them to change their thinking. Worrying, of course, is a thinking problem, overthinking. Existential therapy can be useful, looking at life roles, death anxieties, a variety of anxieties that can cause a person to worry. Giving voice to anxiety is a useful approach with Gestalt. I really like some of the Gestalt approaches. They have this nice creative flair to them. Imagine asking a client to have the anxiety speak. If you were to give it a voice, what would it say? It's just a nice way of starting to help the client to connect to their physiology, or in addition, their thoughts as well, to speak them out loud. Solution-focused brief therapy. You can use scaling or exceptions for things like anxiety. When doesn't it occur? How bad is it right now? When was it 1 point lower, if you will? And strategic therapy, in the family therapy context, strategic therapy comes from family therapy work. A very famous intervention is called paradoxical intention, which is when you ask a client to worry more, for example, or if they're having difficulties with an insomnia, to try to stay up all night. And it has the opposite effect, so the client will worry less if you tell them to worry more. Because I think the client is probably expecting you to try to tell them to rein it in, and so it just kind of sets them at a different cognitive set. They just become more open to the idea of, this isn't the worst it could be. It could always be worse. So I think, again, it's kind of a cognitive strategy, but it can be useful, strategic. Okay, we're looking at obsessive compulsive disorders next. I'm aware that we're about 34 minutes in. I don't want to take up too much time, but I do want to go into it in a little bit of detail, so I'll try to breeze through some of this. OCD, you do need to know this one. This is obsessions, compulsions, or both. You can have either one, that are time-consuming or cause distress or impairment, as in the video that we have watched in terms of the man who spends 2 hours going through his house before he leaves on vacation. It gives you an idea, a sense of just how impairing it can be to have OCD. like the social worker said in the video, some family members, they can't wait around 2 hours every time a person goes out. Obsessions include recurrent, persistent, intrusive, unwanted thoughts, urges, images that cause a person anxiety or distress, attempts at ignoring or suppressing them, often by neutralizing them through the compulsion. So they have these unwanted thoughts or urges or images that cause them issues, cause them anxiety, and the compulsions are repetitive behaviors or mental acts that the individual feels driven to perform, where rules must be applied rigidly, meaning, for example, I must do this every time. I must follow this same procedure or this same flow of doing step 1 by step 2 by step 3. And if the procedure isn't followed to the T, they will have to repeat the cycle until it's done perfectly. Behaviors or mental acts are meant to prevent or reduce anxiety, though seem to be disconnected. So, for example, a person might feel like they need to check the stove every day before they leave, for example. But that's really disconnected, can be disconnected from a person's overall anxiety that let's say that they're going to be socially anxious when they leave the house, or they're going to say something that they shouldn't say. It's not always connected, so even checking the stove might not necessarily be connected to the intrusive thought that the house is going to blow up when I leave it because I haven't taken care of business, if that makes sense. They're not always connected, the obsessions and compulsions. Compulsions are attempts to control the obsessions. Again, it's an attempt that's meant to be adaptive but is not. Insight here includes good and fair, poor, absent, or delusional. So at times, unfortunately, a person can have fairly delusional beliefs about their need to engage in compulsive ritualistic behavior. Other times it can be good or fair. Note that some people, especially athletes, you'll find this a lot if you watch baseball, have ritualized behaviors which they have attributed to a success. So I must, for example, touch the same floor point and swing my bat a certain way before hitting the ball, and if I do that, I'm more likely to get a home run, and if I don't do that, then I won't. A lot of people develop these strange rituals based on this idea that if I do this, I'm more likely to be successful. Hoarding disorder. You may have watched the show Hoarders. If you have not, this is a fairly difficult and problematic issue. It can be very difficult to live in a house of a hoarder just because of how messy and frankly unhygienic it can become. A person with a hoarding disorder has difficulty discarding items regardless of value. Discarding items causes distress. The accumulation clutters and congests living space. And there are some specifiers here, so with excessive acquisition, which is about 80 to 90% of those diagnosed, meaning they can't help but continue to acquire items, even items that are worthless. And insight could be good, fair, poor, or absent and delusional again. Note here that discarding items causes distress. If you've ever had a relative with a hoarding disorder, let me tell you, you can go in and say, look, you don't need these old newspapers from 20 years ago, but getting rid of those newspapers will cause a person significant distress. They're not ready to do it. So just know that if you have a hoarding disorder, it's not as if you just really want your belongings and they're all functional. You're just a collector of something. A lot of the time you're collecting meaningless, valueless items, but you still have a lot of anxiety about getting rid of them. Trichotillomania is recurrent hair pulling resulting in hair loss. It can lead to feelings of shame. I have a current client who has this. It unfortunately doesn't look very sightly, and I think some of the feelings of shame that it engenders has to do with how others look at them in addition to their own feelings about themselves. So if you've had someone with trichotillomania, they can have bald spots on their head, they can have areas of their eyebrows that are missing, and it's fairly noticeable. And you'll find that some people with trichotillomania will want to wear hats all the time, even at school, at church, for this reason. Excoriation disorder is similar to trichotillomania, except this involves recurrent skin picking, which can lead to and also picking lesions. I worked with a 17-year-old who had autism back in the day. This would be 10 years ago now, and he would have significant lesions on his arms that he could not leave alone. He kept opening the scabs again and again, and he would just it was almost like a compulsive act, like he wasn't aware that he was doing it. And when someone would mention it to him, he would stop. But then he would zone out again and he would do it again. And a lot of the time when you're working with people who have trichotillomania or excoriation disorder, there seems to be this dissociative element to it, that they're not fully present when they're doing it, the behavior, because if they were, it would be easier to stop. But they will catch themselves, and it's or if someone mentions it, but without the person mentioning it, they have no recollection or awareness of what's happening some of the time. Okay, we're going to look at some images of hoarding, as well as trichotillomania and excoriation, and I have to warn you that some of the following images are a bit unsettling, especially if you struggle with anatomy and viewing things like excoriation. Just know that some of these images aren't pleasant ones to look at. This is a picture of a couple of hoarders. You will notice the sheer volume of clothes, newspapers, trash really, that's in the middle of the house that the person cannot get rid of. Empty boxes. It just becomes unsightly, and it can be difficult to maneuver around when the house is like this, so packed full. Here's another example. This is an example of trichotillomania. You can see the large bald spot there on the head that the person has picked. Someone who has an issue like this, you can imagine the shame that it would engender, because it just looks unsightly, and frankly it's difficult to hide something like that without a hat or something, and people will ask questions to you about why does your hair look that way, and I think it's just a difficult disorder to treat, as I mentioned, because people are not always aware of what they're doing. Other examples of trichotillomania, this has to do with eyebrows this time. You'll see a couple of places where a person has obviously picked their eyebrows. This is excoriation. Those are the lesions that I was talking about. You can see them on the skin there. A person will open those up, will continue just to pick and pick and pick until they literally open up the skin. That's how damaging excoriation can be to the skin. We're going to watch look at another image in a moment of a child. You can see the excoriation around their face, and just how damaged a lot of the skin is around the face from constantly picking at the skin around the face. This final image the next one is about a thumbnail, and then a excoriation of the face again in an adult. So the thumbnail, you can see a person has just picked away at their thumbnail until there is nothing left. It looks very damaged, the nail. And on the right side you can see a man who has been picking at his skin. You can see the scabs on his skin, very unsightly. Frankly, it looks painful, and you do have people who develop infections. You can get MRSA through having open lesions on your face or other areas of the body if you're not careful with excoriation. Body dysmorphic disorder is another form of obsessive compulsive disorder. This one is a preoccupation with perceived flaws in physical appearance that is unobservable or seems slight to others. So, for example, my one eye looks different than the other, or one ear is different than the other. Repetitive behavior or mental acts that are connected with preoccupation. So it might be repeatedly brushing one's hair, or it might be just a variety of different things, looking in the mirror. This appearance preoccupation is different from an eating disorder because there isn't necessarily an eating component to it. A person does not restrict their eating, or they don't binge eat and then purge. They just think differently about their body than the people around them. Specifiers include muscle dysmorphia, This is when a person believes that they are less muscular than they want to be, for example. You can find this sometimes in athletes. They're just obsessed about the way in which they look in terms of muscle tone. And insight can be good and fair, again, poor or absent or delusional. Because again, body dysmorphic disorder is a cognitive error. It's a way of which you look at your body, and that cognitive error can reach delusional proportions. Treatment planning for OCD and related disorders would include psychoeducation on learned behavior or rituals, things like obsessive compulsive disorder. You want to have the person understand how they have learned those rituals and what they have done for them, because usually there's a function, there's a benefit to doing those rituals or behaviors. It relieves anxiety, for example. Psychoeducation on hygiene is useful for hoarding, just what kinds of germs or what kinds of bacteria, mold, for example, can accumulate in a house if it's not properly taken care of. Body image is useful to have psychoeducation on for body dysmorphic disorder, especially things like the way society views body image. This is particularly apparent when you consider the sheer volume of women, young girls, who have problems with body image and eating disorders. So some education on what is the societal expectation for women, what does a beautiful body look like, what is an unobtainable female form or body. That education can be useful. And I think also hearing from the stories of others, especially if you have people who are willing to talk about in a class, for example, in a group class perhaps, how they are satisfied with their own body image when it's not perfect, can be very powerful. Other women doing that tends to be most powerful. Mindfulness can be useful for trichotillomania or excoriation, because again, a person is not always aware of the hair pulling, of the damage that they are doing to their own bodies. So developing awareness of that behavior can be useful through mindfulness. Intervention and treatment can include CBT, again, can be useful for cognitive restructuring about thoughts related to the obsessional thoughts, for example, in OCD, or it could be body dysmorphic disorder, those thoughts about body image. Developing impulse control can be useful when a person wants to engage in a compulsive behavior or wants to engage in hair pulling, for example, at an unconscious level. And then also being able to tolerate anxiety and distress can be very useful, because a lot of the compulsive behaviors are attempts really at trying to manage anxiety, and so helping a person to do that more productively can be very useful. Behavioral strategies, this kind of is very similar to CBT, can be useful. Things like self-monitoring, so the amount of times that you notice yourself pulling your hair today, the amount of times that you engaged in your compulsive ritual today, your rating for your obsessional thoughts today, things like that can be useful to track day to day how a person is doing, so they can see their own progress. Existential theory and therapy can be useful, looking at the meaning of anxieties. A lot of the time people will worry about fairly big picture issues and engage in micro level compulsive behaviors to manage them, but there are bigger picture anxieties about the world ending, or about what will happen with my life, or about losing someone important to them, are important to look at. Psychodynamic approaches can also be useful if you believe a person has some degree of insight into their obsessions, for example, or their cognitive errors with body dysmorphic disorder, because usually thoughts arrive from somewhere. There's a history to a thought or an obsession, and so if a person is willing and able, it can be helpful for them to explore the history behind their own obsessions. It is I will say that psychodynamic therapy here is a less evidence-based approach than CBT, which is well known to be effective with most of the obsessive compulsive and anxiety disorders. Well, we've reached the conclusion to our video lecture today. It did take me about 50 minutes, and I apologize if you had to sit through that, but hopefully it'll be helpful to you as you approach your next case study, the many-chambered heart. I will miss seeing you all on this Saturday and coming Saturday, and I will see you in a couple weeks where we will pick back up, look at the many-chambered heart, and also look at some medications for anxiety and obsessive compulsive disorders.